I am Dr. Jaclyn Duvall. I'm a neurologist and headache specialist here with Utica Park Clinic in Tulsa, Oklahoma. This afternoon we're going to be discussing telemedicine in the headache clinic, and although I think that many of the practices that we're going to discuss this evening or this afternoon could be generalized across multiple fields of medicine. So I am going to wait just a couple of minutes and let a few more people log in. It looks like we're getting great turnout. I think a lot of people interested in wanting to learn. While we may wait just a few moments for others to join, I would like to thank the American Headache Society and Dr. Amal Starling for asking me to participate in this Facebook Live. When Dr. Starling first asked me, my initial thought was really, why me, or am I really the right person to do this? And I know that there are many other neurologists out there and headache specialists that have implemented telemedicine for much longer than I have. But I think in the wake of COVID-19 and having a clinic that quickly transitioned almost overnight from being fully functional in-person visits to telemedicine in less than 24 hours, I think I've learned a lot in a steep curve. And so I have both advice that I can give as well as just kind of practice mishaps that we've come across or that we've been changing on a day-to-day basis. So I know that this has been a stressful time for everyone, and in the wake of COVID-19, we have all been trying to adapt and grow just as quickly as we can. But I think that many of us in headache medicine have long considered the idea of telemedicine. I've heard many colleagues around the country thinking about telemedicine for follow-up appointments, for example. We know that follow-up appointments are oftentimes that patients have a hard time getting off of work or really scheduling these appointments just to come in for a few moments of face-to-face interaction. And in these appointments, we may be just making very minor medication changes. And so these are visits that probably could be done via telemedicine and increase compliance if we're wanting to make a few medication changes, or maybe looking, asking patients, how are you taking your medications? Are you having side effects to these? Are they overusing analgesic medications? These are all situations that can really be done via telemedicine and may improve our patient compliance and satisfaction with the services that we offer. So what I don't think we anticipated that we would transition this overnight. I know that for myself personally, I imagined I would have 3 to 6 months to research and really decide how to best implement this and have a seamless process in place. But for our clinic here in Oklahoma, we quickly realized that news of COVID-19 was spreading. It was changing by the minute. Literally every hour we had a new process that we were changing or adapting or trying to find a way that we could stay safe and protect our patients and ourselves. And so I quickly realized that we needed to make drastic changes, or one of two things was about to happen. One, our patients would be left with our clinic door closed and without access to help or to healthcare. And our option two was that we just continued along the same practice and exposing our patients, exposing ourselves and society as a whole to an unacceptable risk of viral transmission. And so, like many colleagues around the country, I really hunkered down to do my research. And fortunately for myself, Utica Park Clinic was tremendous in supporting me in this. They really gave me the go-ahead to do whatever I could to help my patients and help keep our staff safe. And so I felt tremendously supported by such a wonderful healthcare system. I know that's not the case universally, but I do think that whenever you can help show administration what is possible or how we can transition this in a smooth way, that you can really make a case for doing telemedicine. So in addition, fortunately, our government realized that changes needed to take place and that telemedicine really could be beneficial during this pandemic. And so they made several changes to lifting regulation that I think have been tremendously helpful. So some changes that were made is that the requirement for telemedicine being practiced in a healthcare shortage area or so-called rural area was lifted. Medicare also said that they would pay for telemedicine services whether a patient was at home or in an office location. They also have offered everyday communication, so things like FaceTime and Skype, and we'll talk a bit about platforms as we go along. In addition, they have a temporary waiver that you have to be licensed in the place where the patient is receiving health care. So during the time of COVID-19, you just need to be licensed in any state in the United States, and you can provide services to patients within both Medicare and Medicaid. What I found interesting was that even before these waivers, CMS had actually made several changes to improve access to telemedicine. In 2019, Medicare started making payments for brief communications via virtual check-ins or e-visits. And I'm going to talk more about language of the different types of visits for telemedicine here in just a moment. It is important that with private insurers that you talk with the companies that you're providing care to their patients. So in Oklahoma, we have contacted private payers. What we have found here is that most of these insurers are following CMS guidance during the pandemic, but it is important to check with individual health plans. The American Academy of Neurology recently released a helpful guide for telemedicine, and it includes a link for some of the private payers. So although not at all inclusive, there are major payers such as Aetna, Blue Cross Blue Shield that are included on this list, and you can actually see whether or not they may be allowing telemedicine visits, to what degree. And we can include a link. There will be a blog to follow where you could actually access this site. So let's start with talking about the three main types of virtual services. And I hope you'll bear with me as I'm going to go through my notes just so I'm not missing certain points. I've obviously never given a presentation like this before. So three major types of virtual services. The first are these televisits, and these telehealth visits are video visits. So these are what are considered face-to-face, your new and follow-up appointments, what we traditionally do in the office. And this is what I'm going to talk about the most as far as how we've implemented these telehealth visits here in our practice at the headache clinic at Utica Park Clinic. But then I also will briefly talk about these virtual check-ins and e-visits later on. What's important to know about virtual check-ins and e-visits are that these are already established patients. They also have to initiate the service. So these can't be patients that are already on your follow-up that you simply call and say, we're going to do your visit via phone call instead of your in-person clinic visit. These really do have to be patient-initiated, and they do have some other guidance as far as how close they can be in relation to any other E&M service that was provided. So we're going to move into the telehealth, the video visits, and CMS has also lifted the requirement that these had to be follow-up visits. We now can perform them for new patient video visits, and these are all video conferences, so face-to-face. What we've told our providers here in Oklahoma, and what I've been sharing with most, is that whenever possible, transition the appointment to a video visit. Any patient that's calling in, really for reimbursement purposes, video visits are going to be your best way of sustaining your clinic. And so instead of picking up the phone to have that 10 to 15 minute conversation about medication changes, let your staff know that for all of these follow-up calls, I'll be doing a brief face-to-face video communication, and we can make medication changes and tweaks via that platform. So step one is considering which virtual visit platform would be best for your need. And there are a number of different platforms that are going around here. FaceTime has been used recently, Skype for Business, Doximity, Doxy.me, Zoom. There are a number, and we can list some more of these on the site just so you have multiple platforms that may be helpful for you. For our clinic in Oklahoma, we really chose two platforms, and I'll walk you through kind of my reasoning and doing this. So The first platform that we felt would really be the simplest, requiring the least amount of learning during the stressful time, was FaceTime. Many of us are familiar with FaceTime. We pick up the phone and call our relatives, loved ones, and many of our patients are very familiar with FaceTime. Even some of our older generation, where we may think that they're not familiar, most of them use this to communicate with their grandchildren. They're familiar with FaceTime. So I found that this was a great platform to transition the majority of our patients. But the next thing that I realized was that I was leaving out the population that didn't have an Apple phone, and I didn't want to exclude them from our practice. And so I've chosen to use doxy.me for the second half of our practice. And so the benefit of doxy.me is that, first of all, it's free. And so that was a huge incentive for me. I could easily go in and sign up, and I'll walk you through that process as well. But secondly, it can be used with an Android telephone. And I think that that's beneficial as well, because I had many patients in my clinic that may not have access to a laptop or a computer with video interface like many of us are privileged to have. But several of them did have an Android phone, and doxy.me will work on the Android phone. So within this website, you literally type in doxy.me. It takes you to a site where only the provider needs to create a profile. So creating the profile was actually incredibly simple. They ask a few questions. You're asked to create your own URL or website. And so for our clinic, I refer to as the OK for Oklahoma headache doctor. And so for us, my URL is doxy.me/the OK headache doctor. Patients are provided with a link to this site, and literally after they click the link, they're prompted to enter their name. And that's the only step they really need to do. They're automatically taken into what I'm referring to as my virtual waiting room. And then when I'm ready to initiate their visit, I click on their name and we're interfaced just like we are in this setting. And so I found that doxy.me and FaceTime has covered the vast majority of my patient population. We have now set up about 150 telehealth visits, and only one of them did not have interface for this. And so that's a patient that I'll be interacting with via a phone call instead. But otherwise, the remainder of these patients found this very easy to use. We've been going live with this now, and it's been amazing. So the next step is setting up a system. So it's important that your staff understands the entire process, but also that your patients feel comfortable and ready for this process for a number of ways. So in our clinic, my front office staff calls the patient to explain the process. The first part of this includes verbal consent. And consent is important for two major things. Number one is they need to be consented for telemedicine and potential HIPAA violations. So during the COVID-19 pandemic, there have been waived HIPAA violations through these third-party services. But patients do need to be aware of these potential violations and verbally consent to participate. In addition, they need to consent for financial responsibility, and this is true for all types of telehealth visits. And so having that consent before you ever complete one of these appointments is essential. The American Telemedicine Association has sample consent forms, and I've actually utilized one of these. We've kind of transitioned it into applicable for our practice. But this includes both consent to participate in telemedicine as well as financial consent in a written agreement. And so for our patients, this is emailed to them with the instructions for their telehealth visit. And those patients, they can take a picture of it and email it back to us. They can fax it back to our office, or they can mail it to us as long as we've had verbal consent as well. So the day of their appointment, they receive a call from my front office personnel. And this call tells them basically that they're checking in for their appointment. So they're told to have their insurance card ready. My front office staff checks them into their appointment just as though they were there in the waiting room. As soon as my front office staff has completed the check-in process, they're told that they will be sent on to my medical assistant. My medical assistant basically does all of our pre-appointment checklists. So just as though they were here in the clinic, she's reconciling medications, making sure a pharmacy is accurate. And then also she's trying to find out if there's any way that we could obtain vital signs. So one thing most of our patients have in their house is a thermometer, and having a temperature would be important not only for our exam, but also for screening purposes during this time. And so we ask patients to take their temperature, we document that. If they have a blood pressure cuff at home, we are asking them to take their blood pressure, and we're documenting that as well. So at the time of their appointment, I know based on our schedule for the day whether they're a FaceTime or a DoxyME appointment. And I basically click on their name if they're within my DoxyME virtual waiting room. And so at this point, I'm interfaced with the patient. I'll tell you that I've created a script for myself that I have on the computer, just because the first couple of these, honestly, were rather awkward. It's kind of like going back to medical school OSCEs, and that the first few times that you do it, you just feel somewhat uncomfortable, and I think that's human nature. So I begin each appointment with this standard script, create one that works best for you, but the first thing that I do is I verify patient location, because that should be documented. I confirm that they have given us verbal consent, and then I explain what's going to happen during the visit. So I tell them that our interaction will be very similar to as though you're sitting right here in my clinic. I will do a neurologic exam, but it will be modified slightly. I reassure patients that much of the neurologic exam can be completed via this FaceTime audio-visual component, and that if there's ever concern for something worrisome where I feel that a patient needs to be seen urgently, that we would make arrangements for that to happen. And then lastly, I tell them that our sessions are not being recorded at this time, so it's important to document that. We do the history just the same as normal, so I'm just talking with the patient, which is a big majority of our conversation during headache medicine. The exam is modified, and again, the American Academy of Neurology has provided a really great 6-page telemedicine reference form, and it includes a modified neurologic exam that could be done via video conference. So you can tweak that according to what things are most important for you. Obviously, in headache medicine, not having fundus examination is somewhat limiting. For some of our other neurology colleagues, maybe not having tone on a muscle motor exam could be problematic. But for a big majority, we can clear a lot of the neurologic exam. I then move on just to my education and recommendations, just as I would within the clinic. I send their medications to the pharmacy. I place any orders that are urgent or immediately indicated. For orders or tests that I think should be done as a result of what the patients told me or their medical history, but ones that are non-urgent, I explain this to them. So maybe I want to screen them for autoimmune disease. Maybe a B12 or vitamin D level, iron should be checked. I explain to the patient that I do think these tests should be done, but I don't think that any of them are immediately life-threatening or urgent, and that I think after the risk of the major risk of this virus has passed, they should come back and get those tests done then. I explain to them that after we hang up, my medical assistant will be calling them. She will schedule a follow-up appointment as to what we've discussed. She also will be sending them with educational material. So we send over our migraine education, our migraine handouts, calendars that we include with all of our new patient visits. And I'm also including an after-visit summary that kind of details exactly which medications or treatments that I've recommended going forward. My medical assistant will explain any co-payment cards to them. So for our monoclonal antibodies or newer medications, she'll still walk them through that process. She'll explain the websites that they can go to since they're not here in our clinic getting those cards. But she really closes up that visit. The next part of this that we get to is billing, and the Medicare website actually provides an overview on billing and codes, but actually Dr. Melissa Coe gave a great webinar with a coding overview that also documented some very good examples of clinical notes as they pertain to the different type of visits. For billing with these telehealth video visits, it's actually extremely simple. So really only the point of service is changed and a modifier is changed. So the point of service that should be selected is the point of service 02. So within Epic, if you actually scroll to the bottom of a screen in a charge capture section, you can click the level of service and it will enlarge into a screen. On the top left corner is where I found that point of service on our screen, and currently it's set at 11. You just change it to 02, which is telemedicine. The next part is the modifier, and actually I was told just today by our coders that Medicare is not currently requiring a modifier during this time. They had previously told us that modifier 95 was needed. I'm still including these within our coding just because if we do have private pay that we should be documenting. But the modifiers that are most commonly used are 95. Some private insurers are wanting either code GT, G as in girl, T as in Tom, which is also telemedicine, or the code CR, which is catastrophe related. And so this will likely change as time goes on, or you may get something back from an insurance company as far as coding and billing where that needs to be changed or modified on the back end. But essentially, for these visits, you're going to choose your level 2 through 5 outpatient new or follow-up appointment, then change the point of service, the place of service, and the modifier. So 02 and 95 are the codes you're looking for. The last part of this is your documentation. Your documentation is going to look really identical to what it does in your usual clinic setting. There are a couple of different things that you should include. And again, the American Telehealth Association lists specific documentation that should be included. So the first and probably biggest code word that should be included is that this service was provided via real-time telehealth video communication. And then you would follow that with between my location and the patient's location. You also want to document that this particular visit occurred during the 2020 COVID-19 outbreak. 2 patient identifiers were used prior to starting this telehealth visit. Verbal and if written consent was obtained to participate. And then I also document that I discussed with the patient the nature of the telehealth visit, including my evaluation and recommendations based on my treatment and assessment, that our sessions are not being recorded, that our team would provide follow-up care in person if and when the patient needed it, and the examination was limited due to the nature of the telehealth visit. So that really summarizes this video visit. Again, I've been really surprised at how seamless our transition into this has been. Major things are choosing a platform that's most applicable to your patients, that can be easily accessed and easily used, that you're getting consent before, both for consent to participate and potential HIPAA violations, as well as financial responsibility. You do your visit just the same as you would in clinic, but modifying your examination. And then billing according to that place of service 02, your modifier 95, and documenting as always. So that is the telehealth visits. I did want to briefly talk about these new codes, just because I think that these are really important for us to start learning about. I will say that initially figuring out the documentation of these has taken me far longer than the visits ever did. But I think if we become familiar with these as a group, these are things that we're already doing in our practice. So we've long heard that, gosh, attorneys are paid by the minute, by the hour, and we do all of this free healthcare on the side. But the truth is that many of the decisions that we're making via phone calls or even virtual check-ins should really be billed according to the work that's being done. So there are 2 new codes that have been created during this telemedicine emergency. The first is a phone call, a virtual check-in via phone call. So this is code G2012. This is a brief communication technology-based service. So a virtual check-in. This is patient-initiated, so a patient phone call asking a question that's not related to an E&M service. So if the phone call is prompting a clinic visit or a video visit, then you would not use this code. That would be applicable to your E&M service only. So this would actually be maybe a patient who's calling in to say, I'm doing well on my current medications, perhaps having this many breakthrough headaches per month. Should I make any changes? I'm nervous to come into the clinic. And so if you call the patient back and discuss the treatment going forward, then, and the call took you between 5 to 10 minutes, then you would use this G2012 code. And so your documentation for this would actually be very brief. I spoke with the patient in regards to their amitriptyline. They're sleeping well at night, not experiencing side effects to this. They're wanting to know if they need a follow-up appointment. We discussed that no follow-up is needed at this time. I'm recommending follow-up in 3 months, and you would bill this G2012 code. You do need to document the time on this. The next new code is G2010. This is the remote evaluation of a video or images, like a photo that was submitted by the patient to you. And so where I thought this would be applicable in headache medicine, maybe someone that sends you a picture of a rash to a medication, maybe there's an injection site reaction that they're wondering, is this normal or expected, or should I discontinue this treatment? Is it allergic or worrisome for hypersensitivity? Or maybe this is something like a pseudotosis, falling Botox injections, where a patient's wondering, do I need a medication for this? What can I expect as far as how long is it going to last? And so for this, you would respond to the patient via a phone call, 5 to 10 minutes, and tell them this eyebrow droop that you're experiencing can be seen following Botox injections. It generally lasts about 2 to 3 weeks and is expected to go away. Your next round of injections will be slightly modified to account for this. And so, so for this, you would code G2010. The major things with these two codes, again, it cannot be related to any other E&M service within the past 7 days, and it cannot be related to an E&M service that is urgent, scheduled within the next 24 hours or next available urgent appointment. So essentially, these virtual check-ins don't prompt a follow-up appointment. So then that takes us to e-visits. These are online patient portal or digital communication. And so there are actually 3 separate codes, 99421, 99422, and 99423. These again are on the Medicare website, and we will link this website in the blog that's posted to come after this Facebook Live is over. But these range from 5 to 10 minutes, 11 to 20 minutes, and greater than 21 minutes. They cannot be related to an E&M service within the past 7 days. So if you saw a patient on Monday and they're calling you on Thursday saying, I'm having a side effect to this, or they're messaging you through the patient portal saying, I'm having a side effect to the medication, what should I do? That's considered in relation to that E&M service on Monday. It can't be billed as a new service. It can be used to select the complexity of the prior E&M service. And then the next thing is it's total time over 7 days. So we all have these patients where we've messaged back and forth maybe multiple times per week, and it's the collective amount of time in a 7 calendar day period. The next thing are e-consults, and these are not something that that I do here in Tulsa, Oklahoma. These are something that we had done quite a bit of at Mayo Clinic. So interprofessional telephone or internet consults. Maybe you work at a site where you're connected with other hospitals that actually send you internal e-consults. And so these codes would be used for those type of internal consults, but I would reference you to Dr. Koh's webinar that she gave that's been recorded. And again, we can provide a link to this in the blog to follow.